This next session of our afternoon presentation is really exciting. We get the opportunity to present one of our most prestigious awards, the John C. McQueen Lecture Award for Innovation in the Field of Maternal and Child Health. This award was established by AMCHP in 1988 to honor one of AMCHP's most distinguished members, Dr. John C. McQueen. The unique part of this award is that the winner actually presents an inspirational lecture as part of our annual conference. I want to put this in context a bit to tell you a little bit about Dr. McQueen. He was the former director of the Iowa Child Health Specialty Clinics, which is the state program for children with special health care needs in Iowa. He's a pediatric neurologist, and in that capacity, he achieved success at state and national levels. As an administrator, clinician, advocate, innovator, and educator, he made his presence felt across the country through his tireless work on behalf of children with special health care needs. At the time of his death in 2009, he was retired from the University of Iowa as director of the National Maternal and Child Health Resource Center. We are so pleased that this award honors his legacy, and we are even more thrilled that today it is being awarded to Dr. Christina Bethell. You're going to get to hear from Christy in just a moment, but I want to take a few minutes just to tell you a little bit about her, and I think you will see very quickly why she was chosen for this award. She is described as being a tenacious and dedicated MCH leader. Through her tireless efforts and passionate advocacy, Christy Bethell has changed the field of maternal and child health. Her contributions are used daily by MCH professionals, child health clinicians, researchers, and policymakers. She is one of the most influential people in maternal and child health measurement in the United States, and her work has heightened attention to critical and relevant concerns such as family-centered care, preventive care, population health, social determinants of health, chronic illness among children, quality improvement, and life course health development. Most recently, she has braided the art and science of mindfulness as a way to improve the well-being of health professionals and the families that they serve. Since 1996, she has been a national leader on behalf of all children and youth, with particular focus on those with special health care needs and their families. Her vision for the development and application of patient-centered health systems performance measurement and improvement methods for child, family, and community health has now been realized. Within the MCH community, she is probably best known as director of the Child and Adolescent Health Measurement Initiative, or CAMI, and the National Data Resource Center for Child and Adolescent Health. Inherent in those activities is the essential role she has played in the groundbreaking development of the National Survey of Child Health and the National Survey of Children with Special Health Care Needs. Her tireless efforts are the anchor for the success of these surveys, both in their content and in their availability to the public. The Data Resource Center was an early innovation in making data available to the public and is the go-to place for state Title V programs looking for data about their populations. And I was talking to Dr. Bethell a little bit earlier, and I said it's really cool when you get to meet the people behind these incredible resources that so many of us use every day. She has initiated and led the collaborative development, validation, and national, state, and local implementation and reporting of child health and healthcare quality measurement tools, such as the Protecting Health Development Survey, the Young Adult Healthcare Survey, the first version of the CAPS and AHRQ, and the CAPS Children with Chronic Conditions Measurement Tool. Her work has also led to nationally recognized methods to engage patients in evaluating and improving healthcare quality and outcomes, such as the Well Visit Planner tool and other innovative patient-centered models to advance the life course health development of children. She has also led the development of the Children with Special Health Care Needs Screener, which is used both to identify and stratify populations of children and youth with special health care needs. She is a highly sought-after speaker for clinical research and public health audiences and has published extensively with over 100 peer-reviewed articles in public health, health services research, and pediatric journals. She is currently a professor of population, family, and reproductive health at the Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland. Please welcome Dr. Christy Bethell to the stage.
Thank you. Wow, I'm just happy to be up here. I'm hoping these lights will warm me up. I was so cold sitting over there. So thank you very much. And I need my little changer here too. So, I consider the maternal and child health and Title V and family leader community to be among the most authentically caring and courageous and creative and determined and brave population of people I have ever met. And it has been such an honor for me to be a part of this community for the last couple decades or so. And, of course, even a bigger honor that you would recognize me and allow me to speak to you in this way for the next 35 minutes or so. So thank you in advance for giving me this opportunity. So as I was going through what I wanted to say, I first wanted to look at who else, in the past has actually received the John McQueen Award. And I found 6 people who I consider to be very important leaders and mentors to me personally. So the first is Merle McPherson, who I met in 1996, which was the year she won the award. And she taught me a mantra about systems of care for children with special health care needs. And it goes like this: coordinated, comprehensive, community-based, culturally competent, family-centered care. How many people here know that mantra too? Okay, so I was going to do I say, you say, like the dancers, but I don't need to do that. I want us to say this together, but we have to say it the way Merle would say it, which is a little bit sing-songy, and at the end you got to raise your fist. So what are we trying to do? Create coordinated, comprehensive, community-based, culturally competent, family-centered care, right? Next on the list is Family Voices, and Nora Wells is somebody I also met in 1996 because we needed to talk to families about how we were going to operationalize this system of care through measurement, which I ended up calling the 7 C's for children with special health care needs. So I went to Nora and I said, well, we need to talk to families. How are we going to do this? And she said to me, Christy, you're just going to have to give us something to bump up against. And I thought, what does that mean? And what I learned it meant is I was going to have to put out a bad first draft. And they were going to rip it up and throw it back over and over again until it got to be right. And that's how we worked with families. And she taught me that my vulnerability and willingness to ask a question when I didn't know the answer and to be able to listen and potentially look silly was the greatest asset that I could ever have. So thank you, Nora, for teaching me that vulnerability is strength. And then Claire Brindis, who won the award in 2001. In 2002, I was giving a IOM Institute of Medicine talk on adolescent health from our Young Adult Healthcare Survey. And Claire very quietly passed me a note. And in it, when I opened it up, it said, "Thank you for what you do." And I keep that note in a book that I read often. And to this day, there are many days when it saves me. So that was Claire, and a big impact on my life to this day. And then there's Ed Shore, who actually nominated me for this award, I understand. Thank you, Ed. I don't know where you are, but thank you. And I met Ed in 1996 when we were starting to operationalize how can we find out if Bright Futures care, recommended care for young children is actually happening, the Promoting Healthy Development Survey. And but in 1987, he and Barbara Starfield and others, another mentor of mine, actually wrote a paper about the importance of families. And this is a quote: "Families establish patterns of health behavior that are stable over time. Healthcare should consider family health data as an important information source." So 30 years later, finally, now that we have the science behind us on the importance of social determinants, we're finally getting around to measure family data. But he was behind a lot of the reason why there's so much family data in the National Survey of Children's Health. So I just want to say that Ed has been a steadfast reminder for me of why we're here, what there is at stake, and what we need to be doing. So that's Ed. And then there's Sarah Rosenbaum, who you awarded with this award in 2010, but I met her in 1990, and she was a major mentor of mine during that time period when she taught me another set of C's, another set of 7 C's, actually. And this was really, we were doing a conference called Beyond Medicaid, Building a Healthcare System for All Ages. And what I learned was that unless we dealt with the policy issues in Washington, D.C. and at state levels, we weren't going to be able to have family-centered, coordinated, comprehensive, culturally based care for children and youth with special health care needs, or any children, that we really had to deal with the policy issues. And those 7 C's were coverage, costs, coding, contracting, capacity building, credentialing, and coordination. And so I learned very quickly that this big vision needed measurement, but it also needed a lot of policy, and that the policy actually needed the measurement to inform it. So this issue of measurement became absolutely critical. And then there was William Sappenfeld, who I'm going to call Bill here, I hope that's okay, who gave the lecture to you last year. And Bill introduced you to a data in action model that said we need knowledge, obviously, we need a social strategy to engage people around that, and we need political will. And there are 6 principles that he set forth around creating partnerships, because partnership is the cross-cutting and fundamental thing that we need to be able to do anything. And 3 C's to watch out for. And that's the 3 C's of partnership that are dangerous to partnership. And that's control and needing certainty all the time, needing to take credit, and competition. And so I have found through thinking about this lecture that I've actually been a data in action aficionado for a longer time than I had realized. I was thinking about Bill's model and how that's applied in my life. And I actually track it back to 11 years old, but I won't go that far back. I'll actually just go to 16. So when I was 16, I was a big runner. I used to run 8 or 15 miles several times a week, actually, around this huge reservoir and park. And I also volunteered at a local nursing home. And I had become very close to an elderly woman named Goldie. And she was trying to figure out why I would ever want to run like that. But I said, well, I'll take you and I'll show you. It's really beautiful and it's, very, very healthy and good for me. And what happened is I was trying to plan this and I realized I couldn't get her into the park because there wasn't any wheelchair access. This was before the Americans with Disabilities Act came through. So I thought, what am I going to do? So I counted the steps that I would need that I would need to take to even get her anywhere near a reasonable access to this park. And I did my calculations and I got my story together and I trotted off to the Chamber of Commerce. And I don't know why I picked the Chamber of Commerce, but it just seemed to me that they should be able to do something about this. And so I made my case with data and a story. And do you know what? They fixed it. I don't even know how, but basically they kept in touch and they fixed it. And this happened to me over and over again when I went to UCLA and Berkeley, seeing an issue, articulating the issue in the story with data, and something happened. So I fell in love with the competent community model. When I was in college in 1985, I was lucky enough to read this article on the competent community. And do you know there's a measurement instrument for the competent community? And so this model is saying that first, to be a competent community, you have to have a commitment to well-being. You have to want to be well and sort of be at the watch for that. And that's not always something we can assume. Self-other awareness, being able to have a perspective on yourself, but also others, and see that. Clarity of definitions, going through the process of clarifying definitions. Being able to articulate wants and needs, knowing what they are and articulate them, and then be willing to have conflict and work through conflict in order to come to agreements. And then participate in full engagement of everyone who needs to be involved in addressing an issue. Resourcefulness, looking for strengths, always seeing that there's so many more possibilities and strengths and resources than we ever usually know are there until we look. And then having a machinery to make sure that that kind of engagement goes on and on and on and on, because it can really never end. And today we have other models like the Self-Healing Communities model that the Robert Wood Johnson Foundation has recently put out with Laura Porter leading it, related to their culture of health model. And core to all of this, like Bill said, is partnership. This is actually from a 1969 article on partnerships. And there's also a measurement tool to find out if you're going to partner, how do you find out how you're partnering? Are you doing tokenism, or is it really shared power? And that's something we really need to think about, because often we think we're participating, we're involving families and we're involving partners, but we're really just asking them their opinion. But we're not really involving them. They're not really sharing decision-making, being able to bump back up against the way Nora taught me that's what it really meant to engage families. So here I was, it was 1990s, and I was coming to Washington, D.C. on a health policy fellowship, all on fire. I'd had lived experience, I saw it work, the competent community, data in action. Just imagine my dismay when I found out that we were stuck back in the 1950s in terms of the data that we collected. So we had whether you were born or died, and we had some data on health, which was really counting up health facilities and visits and things like that. And then we had a little on nutrition. But we didn't have anything on health as far as I could see. And if you're going to engage a community, they might want to know a little bit about that. So I trotted off again to the University of Chicago, where I paved pathways through my left brain to be quantitatively competent so that we could figure out how to advance measurement. And came back from that many years later, and we established the Child and Adolescent Health Measurement Initiative. I'm missing a few steps in there, but that's basically what happened. And the CAMI really was developed to try to fill in some of the gaps in measurement, especially for children, youth, and families, which if you think it was bad for adults, it was non-existent for children at that time. So, and the goal was to really identify shared transformational goals, to start with what are we up against, what are we up to, what are we trying to achieve, and articulate that, and say what do we want to know, and then how do we discern and develop actionable data and tools that can then inspire, not just inform, but inspire, actually make you want to do something, at these transformational partnerships that then, of course, will innovate, act, and learn in order to achieve those goals, and then go round and round and round. So that was the goal. And we had this model of swamping the system. So if we use standardized metrics and we used a similar way of measuring them at every level, then we could have a conversation across all the levels that people needed to have a conversation to improve anything, national, state, local, at the health plan and the clinic level and the doctors and the patients and the service system, so all the way down. So that was the goal behind the measurement work that we were up to. And of course started with the 7 C's model that Merle taught me on how to operationalize and measure that, and came up with more mantras of our own, like starting where you want to end up and sweating the small stuff. And we did card sorts and money spending and every other activity, and many of you in the room were at the meetings that we had. So now we all know that good enough data communicated at the right time and in the right way to the right people is crucial. And we are so fortunate now to have the data that we have. And the National Survey of Children with Special Healthcare Needs was a major victory. Peter Van Dyke at the Maternal and Child Health Bureau led and made sure that happened with many, many others. And the National Survey of Children's Health, which has been under the leadership of Dr. Michael Kogan and his team since 2003. So we have this data, but the availability wasn't enough. We knew we needed to get it out. So Paul Newacek and Nora Wells and I sat at a Starbucks trying to figure out how we could make the case for creating a system to liberate the data to the common person so that they didn't have to go through any process at all to find out what the results were in their area by numerous subgroups. So we created the Data Resource Center. Didn't know how we were going to do it. It was an idea in our heads, but we ended up having the opportunity to pilot it over a few years, and that was really a joy to try to make data come alive. Did you know that in California, there are enough children with asthma to fill up 20 Staples centers? There are many children diagnosed with depression to fill out 4 Staples centers. And if you put all children with complex chronic health conditions in a bus and lined those buses up back to back, it would stretch the entire width of California. So we have data, and we can tell these stories. But I have a little bit of bad news, and then I'm going to go to some good news. But the bad news is that after all this time, it turns out data doesn't really improve systems, people do. And we still only have about 1 in 5 children with special health care needs who are meeting that systems of care criteria in this country. We'll have new data in 2016 with the National Survey of Children's Health, and it maybe did get better. But so far, we have not seen a shift in the proportion of children in the country who have a medical home, whose conditions affect them on a daily basis in a large way, so functional health and missing school. There's just as many families today who cut back and stop working because of their child's health needs, and that often has to do with issues of not getting supports and care coordination and so on and so forth. So we have a lot of work to do. The disparities persist. In the states with the best results in terms of maybe an outcome like overweight obesity, we see the highest disparities across income groups. The same thing with adverse childhood experiences. So we really are seeing a lot of disparities and inequities still. And a lot of myths persist about what the best strategies are. For example, we often confuse relative risk with absolute risk and focus on the highest risk group, but not necessarily see that the whole population is dealing with these issues. Most children who have obesity in this country are at risk are not in poverty. Almost all of them have access to parks and recreation centers. That's probably not going to be where we're going to make the biggest change, but that's often been where people have focused because of this relative risk issue. So it's very important that we continue to educate ourselves, to become data literate, look deeply at the data we have, and pass that on, because there's a lot of turnover, I think, as Eileen said this morning, and we need to keep every generation of people informed. So I'm going to go back to the focus groups that I started with Nora back in 1997, and every statement in them, I read them all again for this talk, are exactly the statements I think that families would say today. And there are many of them, and if you want to read them, I can share them with you. I think I sent them all to Ed one day. He asked me for them. But I'm going to read one of the quotes, which is this: I think doctors have to have faith in what the parents are saying, and not to be afraid. If they don't know what's going on, not to be afraid to say, I don't know. I just think of his pediatrician, I'm paraphrasing just a bit. He didn't even want to talk to me. It was like, oh God, here's Lisa again. I mean, like, Lisa, I don't know, but I'm going to find out for you. But they don't do that, and it's a cop-out. And this is, again, to be able to do what we need to do for families, we have to be vulnerable. We have to be able to say, I don't know, and not wait till we have the answers to start to engage. So here's the good news. Variation is information, as you know, and there's a lot of it. There's a lot of variation across states in all of the measures, which means there's some that are doing better than others. 30, 40, 45% difference often in many, many measures. So we can learn. And if we dive into this data, we're going to find out that there's a state out there that's figured something out that we don't know, and yet we don't really always go the distance in looking at that. Developmental screening actually has improved, mostly because we've addressed some of those 7 C's that Sarah taught me about. We addressed coding. That was the first problem. How do you code for developmental screening? Coverage and costs, and put it in your contracting and hold people accountable for it. And you know what? Lo and behold, it starts to get better. So that one improved. But you can't really legislate family-centered care. You can't legislate the way people interact with each other. That's the spirit of it. We have to have the spirit. We can't just have the transactions. And so we haven't seen improvements in those aspects really at all. But we do have a lot of variation, and we have innovation, and we need to look for it. So getting needed mental health services is up to 81%. Or 86% in one state, and 40% in the lowest state. Don't you want to know what that state is, what they're doing? I do. We have hotspotting maps on the Data Resource Center now where you can at a glance see that no state is doing great on every performance measure. Everybody has something to learn from everyone else. There are very few states that are in the top quartile on any of these national performance measures, and we can look at it at a glance. So here's an example. I call it the Judy Shaw effect. Vermont actually happens to be in the top quartile on a number of measures, but what do you know about Vermont, if any of you know Judy's work? They've been at this quality improvement business for a long time, longer than any other state that I know of. So they're the top. But still, if you unbundle that measure into its component parts of out-of-pocket costs, being able to see the doctors you need to see, and overall getting your needs met, Vermont actually isn't the top on any of those. That's a math problem I can explain to you later if you want to come up to me. But so we have to keep unbundling it down and down and down. So we have medical home, we have the 6 domains, and we have the items within them. And if you really look in there, you're going to find a lot of information. And that's kind of information that you can actually access today on the Data Resource Center. And other good news, what we do matters. It turns out that if children and youth have a medical home, they're much more likely to get transitioned to adulthood services, and those parents are much less likely to cut back and stop working because of their child's health. So we have so many success stories that are hidden in this data that we need to keep pulling out. So this has led me to 6 wishes in maternal and child health. And these wishes are to free our brilliance, to take on transparency, to prioritize possibility, to take on trauma, to become we ninjas, and to brave being. So I'm going to go through my 6 wishes, and then I'm going to close with a poem for you. So the first part of Free Our Brilliance really is to make it easy to do the right thing by paying for health and by re-examining the way we finance care. So when we're up against the possibility of a withdrawing and replacing of the Accountable Care Act with the innovations that it's put in place around financing, I worry a lot. It's been since 1930 that everyone's known if we don't start incentivizing and paying for health instead of disease and treatment only, we're never going to get ahead of the curve to be able to optimize on the possibilities for prevention, well-being, and whole family, whole community health. So whoever in this audience is in a position to maintain financing mechanisms that make it easy to do the right thing, because people have to be incentivized and rewarded for that. We can't expect people to go against their own basic survival in order to do the right thing. So that's the first part. And the second is to maintain, whoops, that was weird. Okay, let's try that again. Maintain our data resources. You know, we take it for granted now, but anybody in this room who was a part of it understands the fight that goes on for Dr. Kogan and the Maternal and Child Health Bureau to maintain the resources for these national surveys. It is a big deal. Everywhere you go, advocate to be able to keep the data that we have. We are in danger. Already we are way behind the European countries in the data we collect, and I have many, many quotes and examples I can give you. So we need to be advocating to maintain the data that we have. If you care about it, do not take it for granted. Make it one of your key advocacy points everywhere you go. The second is we need to overcome the barriers to sharing data, because if we don't start sharing data and telling the same story across all our partners, it's going to be very hard to get a whole picture and engage everyone. A lot of the issues with sharing data are not technical and legal. They're actually motivational and political. And so we really need to overcome and not get too scared, because a lot of times you think you can't share data, and you can. It's not illegal. And I got my CDC person here shaking his head, so thank you. And then the next is what I call free the people. We have IT and web-based platforms. People can go online and find out, how's my care? Am I getting the care I need to get? What could I do to be the driver of improving care? And how we can do that in a way that also collects population-based data at that local level is something we have solved. We know how to do it, and we can keep going. So we want to give families the power to say what 70% of everything you want to know about health or healthcare quality you have to get from a person anyway, and really give them the power to engage. So the next wish is take on transparency, and there's 2 main points I want to make here. The first is if we're going to take on transparency, we need to be more curious than afraid to find out the truth about how we're doing at every level, all the time, over and over again. And we also need to be able to share accountability, and that means we share data and measures in common. So we've, over the last year or so, through our Maternal and Child Health Measurement Research Network project, which is a MCHB funded project, looked at all of the measures that are being used by 11 different MCH programs in the country, and we found 820 measures and 205 topics, meaning there's a lot of different ways to look at the same topic. And we found that there are only 13 of these topics that are shared by any 2 or more of those 11 programs. And in most cases, they're not measured in the same way. So, shared accountability might require sharing similar ways of measuring things, measuring the same things, and we have a long way to go. We've identified 8 different types of gaps in MCH measurement. And only one of them is concept gaps, gaps in actual measures. And many of the gaps are really about being able to create harmonization, being able to get the data out to people, help them understand how to use it, and actually take data to currency, which means take it to action. So the next big thing under being able to take on transparency well is to measure the right things. And, you know, what we found in children's health is that we haven't improved a lot, but that's also true for adult health. America's Health Rankings just came out with their report not too long ago that in those areas of transaction, things you can legislate, like health insurance, and even in smoking cessation, there's a lot of things we can legislate, no smoking rules and things like that. We have seen improvements. But when it comes to obesity, it's increased. Preventable deaths has increased. Drug-related deaths has increased. Self-perceived health status has decreased. And we're on the rise with what we call the diseases of despair, diseases that are associated with overuse of alcohol and drugs and things like that. So this points to me that there's a deeper root than just getting access to health care. And it has to do with, I think, the social and emotional well-being of the people in our country and the relationships and social connections that they have that really are a cross-cutting feature of being well. So we have the social determinants of health, the social and emotional determinants of health is probably the way I would prefer that we talk about it. So I'm going to suggest that this is introducing a fifth wave of public health. That's not my term. There's actually a paper on that. It's a well-being wave. So the first wave was public works, healthy water. And the second wave was germ theory and antibiotics. The third wave was making sure we had the structures and systems and bricks and mortar to provide services. The fourth wave, which we are sort of in, is the wave of reducing risks. And what we want to do now is actually promote the positive, okay? So that's going to bring me to my third wish, prioritize possibility. So we're living in a time when I think well-being is upon us, and I think it's often within and between us, and it relates to how well we're doing socially and emotionally with each other. And that is a lot of what's up underneath, being able to take action in healthy health behaviors, and so on and so forth. So neuroscience, brain plasticity, epigenetics, and the social determinants of health literature really all pointing to the possibility to be well. And earlier, when we had our dance crew, she mentioned growth mindset. How many of you are familiar with the concept of a growth mindset? So the growth mindset basically means we have to deal with those 3 C's that Dr. Sappenfeld was talking about around the need for control and certainty, needing to take credit in competition. All of those things come from fear in many ways. A growth mindset is a courageous mindset, one where we take the courage to care, to collaborate, and to create. And so in a growth mindset, we're really focused on learning as a good in and of itself, being curious and tolerant for the complexity, not needing to always have it figured out so quickly. And have a developmental mindset, which says, oh, that didn't go so well. Maybe I need to improve in a certain area. I wonder what that area is. I wonder who can help me with that, and not get stuck with the idea of we have to be perfect. And then to experiment, small experiments with rapid feedback, and that's how we can innovate, like in many of the coins that are being funded through the Maternal and Child Health Bureau. We need to really, really be willing to learn. And so a growth mindset is up underneath all of the possibilities that we have to promote well-being. But I think we may be suffering from a hard, easy cognitive bias, which is not something I made up either. It's a concept. Because we have information and studies that even show that when we tell a coherent narrative about our lives, even if we've been through a lot of trauma, it helps heal us and integrate our brain. And that the biggest connection between healthy bonding with a child and the mother is whether the mother has a coherent narrative of her life. And that we know how to do that and tell our stories, and it helps a lot. Should we be measuring that? We also know that when we teach youth who are depressed that there's a possibility to grow and to change, and teach them a growth mindset, that their depression symptoms decrease almost immediately, and they stay that way. This is a randomized trial. Should we be measuring that, a growth mindset? So there's implementation happening to some extent on these possibility sciences in home visiting. There's some trials, I think also through the Maternal and Child Health Bureau. But we have a long way to go and a lot of opportunity. And we luckily have some data that we can use to start to push that upstream even further. So don't worry too much about the details of this graph, but mostly what it's showing you is that when children, even who have had adversity, are taught resilience, and it's not a trait, it's something we can learn and teach, they're much less likely to go on to have an emotional, mental, or behavioral health problem, even if they've been exposed to a lot of adversity. And then also from the National Survey of Children's Health, again, don't worry too much about the graphs, I'm going to give you the punchline. If the parents of the child is able to cope well with their own stress, The child is also much more likely to be resilient, of course, and when there's relationship with an adult and communication that is going strong between the parent and the child. So again, pointing to the power of relationships to heal and also prevent. So children are more resilient when their parents are doing well, and yet what we know is that for children who have adversity, only about a third or so of the mothers have excellent or very good health status. So it's the big problem. If we can't, if the parents are the most important factor for the well-being of the child, then we need to focus on the family, back to Ed's point. So this brings me to taking on trauma. Intergenerational trauma, family trauma, community-level trauma. We've been through it. There's a lot of evidence for it. And we actually know a lot about what we can do. And we know the requirements for well-being involve safe, stable, nurturing relationships. We know that about half of children in the U.S., again because of the National Survey of Children's Health, have adverse childhood experiences, which we show in thousands of studies being linked to health early and across life. And we know something about the impact on flourishing. There's 3 things measured in the National Survey on Flourishing. One has to do with motivation, whether children are usually or always curious and interested in learning new things, whether they're usually or always able to stay calm and in control when faced with a challenge, and whether they're able to maintain attention and complete tasks that they begin. And for those that have no adverse childhood experiences, it's about 55.4%. Lots of opportunity still for proactive promoting of health. But when we get down to children with 4 or more adverse childhood experiences, which is a very high proportion of children who are in lower income homes, only about a third have these qualities. And they're pretty basic qualities, actually. But there's a third that actually do have flourishing even with that adversity, and I want to know who they are and what's going on there. So that's something we need to move toward. And it's equally unequal. So it is true that you're more likely to have these adversities if you're in a lower income home, but once you have them, it's equal impact on whether you go on to have an emotional, mental, or behavioral problem across all income groups. So we are all impacted, and this is all of us. The public knows that stress, we've had a great acceleration in inputs, and the stress in our society is very high, and the public agrees that stress levels are higher. And this is a poll of adults looking back on whether they think children these days are having more stress and issues with coping and staying positive than they did when they were younger. And we also have 50 years of research linking safe, stable, nurturing relationships to healthy development, well-being, and stress. So if you want to see that, I can give that to you. So this brings me to my 5th wish, which is to become we ninjas, that there's really only we. There is no me, you. There is only we. This is actually a neurobiological fact. And it means we need to rewire Maslow's hierarchy. It's not at the tip of the top where we connect and have social connection and belonging. It's in the center, and it's dictating a lot of the other pieces of this hierarchy. So even the Joint Commission, which accredits hospitals and health systems, agrees with this in many ways. They have a model called the High Reliability Organizations Model that sounds a lot like that Competent Communities model that I told you about when I began. And in this model, collective mindfulness is the defining characteristic. And if you don't believe me, you can read the Health Affairs article on Mark Chassin, the president. Actually, this is a quote from him. And collective mindfulness is defined on 6 parameters. The first is the capacity to continuously update our situational awareness, meaning being able to be aware of what's happening now, and now, and now, and now, and knowing that it's always changing. And this is what teams need to be doing when they get together in health systems or in communities or in families, even potentially, to work well together. The next is preoccupation with failure, which is really my take on transparency, being more curious than afraid, and actually really looking forward to finding out how it went. And if it didn't go well, that's even more exciting because I get to learn. And so really being preoccupied with failure is what they call it. Reluctance to simplify, and so that we're not trying to simplify just to make things feel safe and secure and certain when it's really actually very complex. The next is the sensitivity to operations, that even if we have a checklist on how something goes, we still show up with our presence every time, because that's what really is going to make it work. The next is deference to expertise. Who's the right person to do this? Is it the family? Is it me? Is it the doctor? Is it the nurse? Is it the person in the community? Is it the janitor? Who is the right person? So really downing our ego to the point where having to be experts and saying who's the right person to do this, who has the information, and giving them the baton to do the work. And the final characteristic is commitment to resilience. So resilience has been a buzzword in many ways, and I'd just like to say a little bit more about resilience. Nicholas Tabar has written a book called Anti-Fragile. And in it, he's taken this concept of resilience and broken it down into a couple places. Obviously, there's being fragile and anti-agile, which where you're protecting against change and not really adapting. The next is being robust and maintaining under pressure. The next is being agile and adapting under stress. And then this becoming anti-fragile or evolving in the presence of stress. So when we're fragile, we're resisting. Actively resisting disorder and resisting change and protecting. When we're robust, we're managing change, we're managing stress, we're maintaining only, and that's often what's called grit or bounce back ability. But we can go further than that, where we embrace change and look for what does it mean for how I need to adapt and change. And then the fourth, which is anti-fragile, is actually seeking and understanding that we are evolving and looking for what that evolutionary next step actually is, and embracing disorder, adapting, and then moving toward thriving. So here's a mantra for becoming anti-fragile from one of my favorite poets, John O'Donoghue. And he says, very often in difficult work projects, there is a secret shape waiting to emerge. If you concentrate on releasing the hidden possibility within your project, you will find a satisfaction that will surprise you. To be able, though, to be in that kind of a state in your work, we need also to feel safe. So we talked about safe, stable, nurturing relationships being important to children, but they're also important for us as adults. We need to feel safe. I need to feel safe. And it turns out in David Rock's book, Your Brain on Work, a great book, he talks about the SCARF model, that we all need to know that we matter, that we have some agency and certainty about what's going on in our environments, that we can choose and have agency, and that we connect and belong and we're wanted, people want to connect with us, and that we can trust what's going on here is fair. So if we're in partnerships and in work relationships and these things aren't there, you can bet our brains are not on the table really creating. They're in defense of some kind. And so we have to look at how we are with each other, and that often is portrayed best in how we listen to one another. And people know how we're listening to one another. And when I'm stressed, I don't listen so well, and I know that. And so I need to manage that in myself so that I can show up and really partner. So the first level of listening is from habits to just prove what you already know. The second level is maybe trying to learn a little bit something new about what someone else thinks, but still mostly confirming what we already know. The third is trying to understand another person, really. But the fourth is really getting into that anti-fragile space where we listen with the possibility and expectation that we might actually be changed by what we hear, and looking for the opportunity to grow and learn and develop and change based on what we hear. So that brings me to my final wish is brave being. And this is one of my favorite quotes. The success of the intervention depends on the interior condition of the intervener. Where inner work helps our external work, and the first MCH competencies Laura Kavanagh knows is self-reflection, taking that very seriously. And Theory U is something the MIT Management Lab has talked about, alerting us to look for the blind spot from where our behaviors, thoughts arise from, which we can get in touch with when we become still. And the science of leading yourself has actually even been portrayed as the key missing piece to healthcare reform. There's another article on mindfulness and healthcare reform. It's quite amazing. And of course, mindfulness practice helps us cope with stress, to respond versus react. There's about 1,000 articles or more linking it to just about every health benefit you could imagine, including improvements in our DNA and down to their little teeny tiny tippy-toe telomeres, for those of you who know those studies. So it's important, and it improves our brain in many ways. And Dan Siegel, who wrote The Developing Mind, around the same time Neurons to Neighborhoods came out, which many of you may know about, bringing together the sciences, the neurosciences, and how that informs us about how children develop and how they can develop in a healthy way. So his conclusion was that mindfulness was really central to the developing mind, and especially to the parents and the people and the adults in the children's lives. And so much so that he started out as writing The Developing Mind, and then established the Mindfulness Awareness Research Center at UCLA. So he says you need 12 minutes a day of practice of some kind. So most of you know that, or some of you know, most of you do not know, but some of you know that I teach mindfulness-based stress reduction on the side, and that in the last little while I've had the opportunity to work with a young girl who I'm going to call Sweet Pea. And she wrote a poem about her experience with healing herself through the support of me and others to take on her trauma. And she has 8 adverse childhood experiences. So it's taking a village. But here's her poem. It's called Only Begins. I'm going to end with this, and just a few more comments afterwards. So Only Begins is her title for this poem, and my title is, it's a trauma-informed ode to epigenetics and the microbiome. That's how I think of it. So it goes, I am in the world and the world is in me. From my nose to my toes to my belly to my knees. What's in is out. What's out is in. Endings can't be endings because there's only begins. Begins are like flowers that lean toward the light. When I'm aware of what's there, it's never really night. The scariest of scaries are just frights from before. I'm almost never afraid of what's actually at my door. And so I want to ask us, what is actually at our door right now? Are we afraid, or are we engaged in the possibility? I think, well, I'm going to go back again, that one, that well-being is upon us, as I said before, and within and between us, and that we actually are more the medicine than we would ever know. And you'll find me from here on, I think, sort of trying to live on the edge of my own evolution, being as anti-fragile as I can manage to be, but I need you to do that. And really trying to advance the well-being mindset to match the mandate of improving health and possibility of well-being for our children, youth, and families, to identify new metrics to match that mindset, and to find out the methods that are going to move those metrics. And in this new science of thriving, we really have to rethink public health and move toward that 5th wave of a well-being public health, where public health is not just the air we breathe and the food we eat, but it's how we engage, it's how we connect, and it's how we love. Thank you for your attention.
So please join me in congratulating Dr. Bethell as the 2017 John C. McQueen Lecture Award winner. And thank you all, Christy, for that really inspiring lecture. Thank you.